Good evening, uh, dear students. Today I am going to talk to you about anesthesia and pain relief. Anesthesia and pain relief. I think all the medical students and paramedical students and students who help in the patient care in any way should have some idea about anesthesia, all of us. Anesthesia means that a person does not feel pain while you are operating upon the patient. We have a very well developed nervous system, and one of the reasons the anesthesia has come into practice is to give relief from pain, number one, and also these anesthetic agents should not permit pain to be felt by the patient. So basically, anesthesia means that, absence of pain while you're operating. And you can further improve it by relaxing the patient and making him unconscious. So therefore, it is not necessary that for anesthesia the patient has to be made unconscious. And it can be, anesthesia can be a general anesthesia or otherwise, which we call regional anesthesia. We'll discuss later on. Anesthesia is not very old, and it was popularized while Prince Leopold was born and Queen Victoria was administered chloroform. This is an old type of anesthesia, general anesthesia, very effective but little risky. Otherwise, there was religious sanctions against making a person unconscious. There was a gentleman in the United States in Massachusetts General Hospital in Boston. It was 1846 when he used anesthesia for removing a vascular tumor. And subsequently, what happened was there was a gentleman whose name was Horace Wells. As always, we must remember those people who have been very, very, who have contributed so much to the mankind, and we don't know their names. They are shining like stars in the sky, but those gentlemen must be remembered. Those people who have made centuries back, they have devised certain things, they have discovered certain things, they have invented certain things, and one person, his efforts, his thought process, his perspiration, his relentless work throughout the life, whether it's the history or is the languages or is surveyor general or is the railways. So what I mean to say is that one person who has made the lives of so many people, millions and millions of people, good. So they must be remembered. And one such person was one gentleman who's administered anesthesia, nitric oxide, to a person long time back. So with these words, I would say that all of us should know something about anesthesia, but there are certain principles of anesthesia. What are the principles of anesthesia? That this is when you are giving anesthesia to a patient who is lying on the table. He is offering his life in the hands of somebody else, including the machines. A person who is under anesthesia is totally and absolutely dependent upon individuals who are tackling his disease and the machines. So therefore, we have certain principles in anesthesia. Number one, I'd like to talk, mainly I'm stressing on general anesthesia. I'll talk about regional and topical and things like that, topical anesthesia, the local anesthesia, the transverse abdominal anesthesia, the spinal anesthesia, the epidural anesthesia, the total intravenous anesthesia, the bias block, the intravenous anesthesia, and the things like that later. But once we are talking about general anesthesia, it has to be a teamwork. We cannot be at loggers drawn with or having some kind of. We are tackling for a moment, we are focused to a patient. So therefore, there has to be a teamwork between the gentleman who's going to operate, is a surgeon, and the gentleman who is going to administer anesthesia. People have got a very wrong notion. Sometimes I've seen many people who are not linked to the surgical practice. They have not gone to OT. They don't go inside the OT. And they feel the surgeon operates. What are the requirements? So many people there inside. When surgeon is there, he is operating. What are the other people doing? I had to remind some of these exalted academicians that when a surgeon is operating, somebody requires to expose the site of operation. Somebody has to hold the retractors. Somebody has to make his life easy. Somebody has to make the abdomen relaxed. Somebody has to give him the instruments. Somebody has to give him the sutures. He has to talk to someone when see the person is bleeding. On the table, what is the reason? The anesthetist. Anesthetist alone cannot do everything. He has to have an assistant who is pushing in the drugs. Somebody is looking at the vital parameters. Somebody is monitoring the vital parameters. And somebody is checking the anesthetic agents and the tubes. If something has gone wrong or like that. So it is a teamwork, and quite a lot of people are involved in this. Let me tell you that treating a patient, operating on a patient, is not solely the responsibility of a surgeon and the anesthetist. So many people are required. We require help of so many people. So therefore, I was talking to you about the principles of anesthesia. When you are operating a person, first and foremost, the surgeon who is going to operate on a person, he has to take a history of the patient, what disease he is having, how long he is having, what is his family history, what is his past history, what is social and personal history, smoke or drink or things like that. All these things have to be asked. Did he suffer from any disease? So that which has got direct implication upon the results of surgery. Now, if you push on a person into anesthesia, he is having diabetes, they'll go into complications. Or a person who has a hypertension, you give anesthesia without treating him, or even in emergency. On table person may have to be operated who is hypertensive. He may be having some diabetic problem. So therefore, each and everything should be known about the patient, whether he is fit to undergo surgery, whether he is unfit to undergo surgery. If he is unfit to undergo surgery, his deranged physiology has to be stabilized before he is taken for surgery. But then the situation may arise, a road traffic accident, person may require surgery at once, immediately. He requires resuscitation, he requires IV fluids, he requires blood transfusion, he requires things like that where he requires resuscitation. So therefore it's an emergency. So anyway, what I'm talking to you, that surgeon and the anesthetist, they get together for the good of the patient, so the outcome has to be successful, and so that in a perioperative recovery is good. And what I mean to say is that we must have a proper checklist. When we are administering a person anesthesia, we have got to have a checklist. That have we done this? We have given pre-operatively, we have given sedation, what induction agent we are going to use, what inhalation anesthesia we are going to do, what gas is going to inhale, how much muscle relaxants we are to be given, what is the approximate duration of the surgery. All right. So therefore, all these things have to be looked into, and patient has to be prepared accordingly. If patient is having diabetes, please manage the diabetes first. If he has a coronary episode, please manage his cardiac status. Is he having arrhythmia? Please tackle that. So that it should not happen that if you take the patient like that, without examining, without stabilizing his deranged physiological functions, we may not have good result. So the pre-operative preparation of the patient is very important. Consent has to be taken. Patient has to be explained about the procedure, and he has to be taken into confidence. He must win his confidence. He should have faith in the team who is going to operate upon him. So what we say is that a proper pre-anesthetic, which is called PA checkup, PAC, pre-anesthetic checkup has to be done. The anesthetist examine, surgeon has already seen. He will try to push on the surgeon for surgery. But anesthetist has to see his cardiorespiratory status in particular, any metabolic disorder, and then he decides what kind of anesthesia the patient is suitable to. If it's not suitable, his cardiac status is not good, possibly he may require regional anesthesia. All right, not knock him down, he is conscious, but he can be made to sleep, and we give a regional anesthesia, which we will discuss later. So, when we are talking about general anesthesia means three things, triads, three things. One is that patient who's undergoing surgery should not have pain, analgesia, total analgesia we call it, pain relief, isn't it? We have got acupuncture and things like that will give you pain relief, but what is the problem? Patient will not become unconscious. So when you're operating, there's a pain relief, no doubt about it, but along with it, patient should be unconscious, amnesia. He should not know anything about the procedure, what is going on. And thirdly, the patient's muscles have to be relaxed. If the person is not relaxed, he's tense, how are you going to operate? You're doing laparotomy, the abdomen is tight. How the surgeon is going to operate and go inside, put his hand inside, put the instruments inside? So therefore, three things in general anesthesia. Three things are important. That we must give him effective anesthesia in a sense that he is unconscious. He has got amnesia, analgesia, no pain, and muscles are relaxed. So therefore, when you have taken the person to OT, he goes inside. Pre-operative counseling has to be done. So what we do, the first thing what we do is, you see that everybody is there. You see, imagine patient is lying under the headlights. There's so many people around putting on caps, masks, and small child will get frightened. What is happening around? Even any normal person, even a surgeon himself might undergo surgery, so he will also be, for a moment, here the moment is not likable. Till the time a person undergoes induction. Induction means that we are slowly going towards making the patient totally anesthetized. Induction. And at all times, what we used to do is we used to give thiopentone, intravenous thiopentone. The drugs which we use, intravenous anesthetic agents now, just remember them. One of them is thiopentone, which is given for induction. Patient, gradually, when you're pushing the drug inside, he goes to sleep gently, and then he knows what is happening around, but he cannot move. He's inducted, thiopentone. Some of the people describe the induction as a very, very pleasant, peaceful situation. So like he's going afloat. And then thiopentone. Thiopentone is a drug which brings the metabolic rate. It reduces the intracranial pressure also. There is a rapid induction in this, patient is induced rapidly. But then it's short acting. Then another agent which we are using these days is Propofol. The Propofol has got a smooth induction. It is hemodynamically, it is good. Doesn't affect much of the cardiorespiratory status or things like that. And it blunts the autonomic reflexes. And then we have got, etomidate and kind of steroid. Another thing is ketamine. Ketamine, when we push it inside, it makes a person unconscious. Patient become unconscious, but he preserves his respiratory function. His breathing continues. Is a useful for a very short procedures, very short, where you're going to take only 5 minutes, 10, 15 minutes or so. Ketamine, intravenous ketamine. But one of the problems with ketamine is once you have given ketamine, I've seen many cases that a person has been ketamine, we are operating, and once he is recovering, starts shouting, he goes into delirium, and some people talks good things, and some people start abusing. So it depends. Anyway, now I was talking to you about general anesthesia, that induction is done by certain drugs like thiopentone, or you may use propofol. It's all right. And once the person is, it's called rapid sequence induction, all the patient. And we use sometime inhalation, before induction, we some kind of a inhalation induction is also done. And particularly, with some fluorine, what you call that, sevoflurane and isoflurane. Some people, even small children, they are looking around left, right, they are frightened. So they are given this inhalation anesthesia, and so go to sleep, and then you will do a venipuncture or things like that. Okay. And if there is a short procedure, you can do a total intravenous anesthesia also. And you use inhalation agents. Now, nitric oxide, earlier we used to use, it has got analgesic and anesthetic properties also. But now once we have induced the patient, now patient is sleeping, he is unconscious, now he cannot maintain his airway. The first and foremost thing in any patient is we have to maintain the airway of the patient. And how do you maintain the airway? Generally, by and large, what happens is you will put a Gudel's airway. The tongue will not fall back, but it cannot prevent aspiration. Number two, how can maintain the airway? You can do the chin lift. There's one is the head tilt to the one side, but here what you do is chin lift and jaw thrust. Chin is lifted up and jaw is taken up, so that we hold a mask, which I have already shown you. The mask is put, person has got a Gudel's airway in the oral cavity, Gudel's airway. It goes like this, the tongue does not fall, and patient is already inducted, so we hold the mask over the patient's nose and the mouth. This is how we are maintaining the airway. But this cannot once last for a very long time. The principles of airway is that patency is three things mainly: head tilt, chin lift, and jaw thrust. But here, jaw lift, chin lift, and jaw thrust. It is lifted up, and then we use two things. What are those things? I have already told you. That is laryngeal mask airway. Laryngeal mask airway as compared to the endotracheal tube is less irritating, less harmful. So once you maintain the airway, you have given a induction agent, then you give a short-acting muscle relaxant. Why we give the muscle relaxant? It will paralyze the muscles. Say like succinylcholine. The effect would barely last for 5 minutes. So once you have given succinylcholine, it will relax the vocal cords for 5 minutes. Once the vocal cords are relaxed, you have done the chin lift and jaw thrust. You put a laryngoscope inside. And somebody depresses the vocal cords from outside, the assistant, and we take the tongue to the left side, and the anesthetist sees the vocal cords and pushes the endotracheal tube into the trachea. The muscles are relaxed. Succinyl, scoline. This agent, once it goes, then you cuff the endotracheal tube, so that gastric contents do not go inside the lung. And second is, patient doesn't become hypoxic. Ensure when you are putting an endotracheal tube during general anesthesia, it should not injure the oral cavity. It should only be dislocated. It should not be kinked. It should not go into the bronchus on one side. And the muscle relaxant, suppose this is scoline or succinylcholine, it has certain drawbacks. One of the drawbacks is that it causes hyperkalemia, it causes muscle pain, it causes sometimes apnea also, and it causes hyperthermia. Patient's body temperature will rise. So there are so many types of muscle relaxants. One of them is succinylcholine, quite popular. That is vicuronium. The other one is atracurium. This is just for your knowledge. These agents are used. So therefore, once you have put the endotracheal tube, now what is the trouble with the patient? Now he requires ventilation. You have maintained the airway. You have induced him. You have given a short-acting muscle relaxant. You have done the intubation of the endotracheal tube. Otherwise, you can use this thing. No, in difficult cases, you can use this. I was telling you, intubating bronchoscope, fiber optic intubating bronchoscope, and you over this bronchoscope you put the endotracheal tube and then push it inside. But however, you can also use laryngeal mask airway, which can be quite useful. Now, to maintain the muscle relaxation, once you have done this, now the patient has to be maintained on muscle relaxants for a long time, as long as the surgeon desires or surgery is completed. And there are two types of muscle relaxants. One is depolarizing agents, like I already told you. This is succinylcholine and scoline. We call this is depolarizing agent. And another one is in which this what you call that there is a neuromuscular blockade. And then the first one, what happens is the nicotine acetylcholine receptors opens up the cation channels. This is called depolarization, and muscles are relaxed. But non-depolarizing muscle relaxants, by competitive blockage of postsynaptic receptors, blocking of the postsynaptic receptors at the neuromuscular junction, they provided a longer duration of muscle relaxation. Now, once this is done, we have to use the muscle relaxants. As I've already told you, that muscle relaxants should not cause any kind of complications. All right. Then what we have to do is we have to maintain the ventilation. Once we are done the induction, we have put endotracheal tube, we have given the muscle relaxants, we must continue with the ventilation. The ventilation, we have to monitor the volume and pressure, because if you're giving excessive amount of the tension inside the respiratory passage depends upon the lung compliance, and it has to be given in a fixed dose. Patient is paralyzed, he is not breathing, so therefore you have to maintain the volume and the pressure. Otherwise, if you do not maintain it properly, the person is going to have barotrauma. Okay. While the patient is undergoing surgery and anesthesia, under anesthesia, you constantly monitor the patient. Don't be relaxed. Do not totally depend upon your machines. You have to see. You see what surgeon is doing. Keep a watch on the surgeon. If the patient is bleeding, is he comfortable with the relaxation? I hope the patient is not moving around. So all these things has to be watched. The patient is constantly assessed by basic and universal parameters like pulse, the blood pressure, the temperature, is ongoing urine output, is how much is the percentage of inhaled oxygen, what is the oxygen saturation. All right. And invariably you should have central venous pressure also. So all these things have to be seen. So I would like to say this is briefly about general anesthesia. We have 5 grades which is called ASA grading. ASA grade, what means? The person is fit for anesthesia. You ask the person who is undergoing surgery, you are very confident, the young person, nothing wrong with him, no diabetes, no cardiovascular problems, no systemic disorders. The outcome of surgery will be 100% good, excellent. This is called ASA grade 1. Then comes ASA grade 2. PSA grade 2 means a person has got mild metabolic disorder or systemic disorder. Okay? Well, then he will come out through it. Yes, you know that he has got some problem, but he's not unfit for anesthesia, grade 2. The third one, he has got a severe systemic problem. I mean diabetes or some respiratory problem, systemic, yes, of course. And grade 4 means he has got a severe systemic disorder, the metabolic disorder, which can threaten his life. So you be careful. A diabetic ketoacidosis, you got an emergency, you have some kind of ischemic problem, or COPD or things like that. He has got a severe systemic disorder, and giving anesthesia to such a person and operating upon him, putting under the stress of anesthesia and surgeon, can take his life. This is grade 4. And grade 5 is the outcome with or without surgery. A severe systemic disorder. If the patient is in a moribund state, in a very highly critical state, metabolic acidosis, uremia, and person is a jaundiced patient having multiple organ dysfunction like that. So this outcome may not be good. So therefore, you have to take up a person for surgery, even if during war and battles we have been operating on person, I swear. Generally one should not. No pulse, no blood pressure, but still, I tell you, during 99 Kargil war in my sector where I was operating, I swear in the name of Almighty the God, any person who was brought was alive, myself and the surgeon, both of you, were working in a very, very difficult circumstances, at heights with a hypoxia, low atmospheric pressure. We did not lose a single patient, and I said, why? This kind of person, I tell you, I presented a paper also at a conference, a person, the bullets, the trauma in war does not respect the tissue. One guy had an injury here, bullet here, he had a hernia cerebral, the vein was coming out. A chest injury, the abdominal injury, and again going to the left thigh. So absolutely no chance. It was shockingly, I said, we did his everything. Like necrosed vein tissue was removed. We tackled all his injuries. Believe me, and when he was, after a few days up and about, nothing happened. Axillary artery injury. Somebody has the wisdom of putting a tourniquet here. It was very difficult to manage. This patient was brought to us alive. There's so many things I'm talking about is that strangely certain things also work at that time. While you're working on a very remote, inaccessible places, you are not, there's the cacophony of, thought process of others, they are not inflicting your mind. You are totally at peace, really, I'm telling you. In war zone, you are totally at peace. Nothing bothers you. Just because you are focused. And really, believe me and trust me, there are some forces in some places, if you believe in angels, they won't be sitting in cities, nightclubs, and not at all. There's no business for angels to sit with you. They will be in mountain peaks, snow-covered mountain peaks. If you go then altitude, you will be in a different world, really. There's an out-of-world feeling and experience. Anyway, I'm coming back to the topic. I'm telling you that our job is to do the best, and anything should not affect your mind. There are so many people who will make your life miserable, I'm telling you. I'm talking in other sense. Anyway, this is my personal feeling. But anyway, if you are involved, you're focused, your intentions are clear, you're skilled, you're reading, you're dedicated, you love humanity, you're sympathetic to others, results would be good. Anyway, now let's go to the next topic, that is local anesthesia. Local anesthesia, that kind of anesthesia where the patient is not knocked out, he's not unconscious, you're doing surgery in a very limited area, you are infiltrating the nerve, so you're preventing the pain impulses by going up. Either you are affecting the peripheral nerve receptors. Okay, so therefore you have local regional anesthesia. And the local anesthesia, there are various types. I'll tell you a few of them which we commonly use. One of these is prilocaine. The prilocaine anesthesia, you can do local surgery locally. But one of the disadvantages of local anesthesia, I'm talking about local anesthesia disadvantage, then God forbid if it goes into the vein, it can cause very severe systemic disorder. You have got to be prepared and tackle the emergency and resuscitation of the patient. Patient, if once is going to have cardiac effect, the patient may go into convulsions, may go into coma even. It makes the patient may go into cardiac arrhythmia, and if you have chosen bupivacaine as a local anesthetic goes into the veins, you know the patient has got arrhythmia, it's intractable, it is, resistant to treatment. Nothing can be done at times. You be watchful when you are administering local anesthesia for anything, even to, blunt pain for a very limited short time surgery. The effect lasts sometimes 1 hour, 1.5 hours. So therefore be careful, and it can cause local sepsis. It may cause hematoma also. And like I was telling you, Prilocaine anesthesia can cause methemoglobinemia, and as I told you, that bupivacaine can cause cardiac problems. We may mix Jalocaine with the adrenaline. Adrenaline, if you mix up with the local anesthesia, say, what are the anesthesia? Generally, we use a Jalocaine, which is used 3 milligram per kg body weight. 3 milligram per kg body weight. Bupivacaine is used 2 milligram per kg body weight. All right. And this thing, what you call that, Prilocaine is just 6 milligram per kg body weight. 6 milligram per kg body weight. When we administer adrenaline, so the doses can be increased, but that adrenaline should not be used when person has got some cardiac problems, some ischemic heart disease, or arrhythmia. Then it should not be used. Now, I come to the topical anesthesia. Topical anesthesia means that a person requires some kind of a procedure, intubation or something like that, in the oral cavity. So therefore you spray a 4% Jalocaine into the oral cavity. This will anesthetize, and then you do the intubation or something like that. Then we have got EMLA, eutectic mixture of local anesthesia. The children are scared. You mix up this Prilocaine and Jalocaine, and then you inject it, and then you can, in a small child or a person who's scared of, venipuncture, so the skin is anesthetized when you push a cannula inside. And then we have, God forbid, here I'm uttering the word cocaine. Cocaine is also a anesthetic agent for, nasal surgery or something like that. Here cocaine is a very ill-reputed word, and one should keep oneself away from drugs. A person who is habituated to drugs, who is addicted, who is dependent on drugs, physiologically and otherwise also, addiction, it can play merry hell with the surgeon. You have seen the results. A person who is, say, opium addict, your bowels are silent and you feel this entire obstruction goes on surgery. For the last 3 days is not past bowels, 7 days not past bowels, silent, paralytic ideas. My advice to each and every, we see that these days what we are hearing, the use of drugs among students is rampant, particularly during parties. They got long sticks, called love sticks, and something green, sticky glue type of things, and so kindly, the drugs should not be misused. Then we have nerve blocks. Nerve blocks means that you block the nerves by local infiltration, so that you can do your surgery. Now, if somebody wants to operate on a shoulder, it is not a must that person should be intubated. You get an interscalene block here. This is the clavicular head of the sternocleidomastoid, and this is the sternal head, sternal part of the sternocleidomastoid. So here, this is the place between the scalene muscles you introduce, anesthesia, local anesthetic, so that you can operate on the shoulder. But the problem is you may injure the spinal cord, you may injure the nerves also, it may cause hematoma also, infection also. Another type of anesthesia is at times we require auxiliary block. Auxiliary block means this should be done under the guidance of the ultrasound, that on superior and inferior side of the axillary artery in the axilla to push in local anesthesia. Xylocaine, say. But it should not be, the landmarks may go wrong, but however, under ultrasound guide, if you push the anesthesia, it's very effective for surgery on the upper arm. Thereafter, sometimes you require surgery in the lower limbs. We have got you can block the femoral nerve and the sciatic nerve also. There are landmarks. Femoral nerve, the landmark is just below the inguinal ligament. You push in. The femoral nerve is the most lateral part of the femoral sheath. Medially, there is a femoral vein, femoral artery, and femoral nerve. And then posteriorly, you can use the sciatic nerve for the lower limb surgery. Then there's a transversus abdominis tap block. That this is the anterior axillary fold, just medial to this line, the anterior axillary fold between this is called petit triangle here. You push the anesthesia between the internal oblique and transverse abdominis muscle, and relaxation is fairly good. Okay. Then there is intravenous regional anesthesia, which is called Bayer's block. What did I say? Intravenous regional anesthesia, which is called Bayer's block. Suppose you want to operate on, carpal tunnel. The person has got carpal tunnel syndrome. Sometimes the pain shoots up. There's a diagnostic problem at times. You want to operate on the patient for a lesion in the wrist, so you give him intravenous anesthesia. And I have already told you, for intravenous anesthesia, for God's sake, never use bupivacaine, because it will cause cardiac toxicity and arrhythmia in patient. Only God can save that patient. All right. So therefore, an intravenous anesthesia, which we call Bayer's block, B-I-E-R''S. Bayer's block, you have two cuffs, the proximal cuff and the distal cuff. You inflate the proximal cuff and you push in the medicine inside here in the vein. You put the cannula, administer this intravenous anesthesia into the vein. All right. Once you have administered this intravenous this thing, before that, use a smart bandage. Before you have really inflated it, before you inflate here a smart bandage, what you do is inflate the cuff. What you do is you empty the veins of the blood. Okay, the smart bandage is a rubber bandage, goes around, and it causes total depletion of the blood in the veins. And then you inflate the cuff. Once you inflated the cuff, then push the drug inside. Once you have pushed the drug inside, then you release the proximal one after you have inflated the distal cuff. Okay, you inflate the distal cuff and then release the proximal cuff. Then you have already pushed the drug inside. Okay. So, but one thing is there, after you have completed surgery, keep the cuff inflated for at least 20 minutes. Otherwise, let the anesthesia get fixed to the tissue. But if you have deflated the cuff, so the drug will be go into the circulation. Now, next I'll talk you about neuroaxial block like spinal anesthesia and epidural anesthesia. Spinal anesthesia means this is intrathecal administration of xylocaine or local anesthesia of any sort. There are so many of them, so many of these. 5% xylocaine heavy, and you push in anesthesia at the back. The patient either in the sitting position or patient is lying down with his knees and hips flexed and his trunk also flexed. So you give anesthesia, it should not be higher up. If you give higher up, anesthesia, say about D12, L1, there are chances of respiratory problems, respiratory arrest also. So therefore, in spinal anesthesia, be sure that you are going to a correct landmark between L4, L5 or L5S1. And spinal anesthesia will paralyze both the lower limbs, but it can cause, because autonomic, sympathetic outwards of your compromised, so therefore the person might go into hypovolemia, hypotension. And spinal anesthesia can also cause a little bit of problem to the nerves and the cord also. Be careful. But the another safer anesthesia is epidural anesthesia. The problem with epidural anesthesia is technically a little difficult, and you go into the epidural space and you push in the anesthetic. You can push in the opioids also. You can push in, subsequently higher up also you can place the epidural catheter, and you push analgesics into this, like light opioid, like fentanyl, etc., so that patient does not have post-operative pain. So the original anesthesia includes topical anesthesia, the intramuscular block, transverse abdominal muscle block, total intravenous anesthesia, this thing what you call intravenous anesthesia, Byers block, and spinal anesthesia and epidural anesthesia. Finally, I'm going to talk to you in a hurried manner, pain relief. Any person can have pain. So there are three types of, receptors which may be involved. One is nociceptive, Nociceptive, The other one is neurogenic pain, and the other one is psychogenic pain. So the nociceptive kind of a pain occurs when there is some kind of a musculoskeletal disorder. There is a pain from cancer, there is pain from infection, there is a pain from injury, so that these pain receptors are stimulated. So for these kind of things, you require a mechanism, a WHO guided step pattern of pain relief. The other one is neuropathic pain, which you have in diabetic neuropathy, or you have trigeminal neuralgia, or it can be post-herpetic pain, which involves the central nervous system. So for these kind of pains will require, this type of pain. Neuropathic pain is something like shooting pain, burning pain, and in this person we have, may have numbness. There's a enlargement in the area of the pain, and sensitivity, allodynia you call it. There will be numbness, and these kind of type of persons are suitably may be treated by something like anticonvulsants and tricyclic antidepressants. Then we have got a psychogenic pain because of psychological effects. Now, how do we relieve pain? You can also use local anesthesia, not only for surgery. You can use local anesthesia for relief of pain. Push in local anesthesia, infiltrate it safely at a place where the person is having pain, because whatever the reason is, and it will give you pain relief. That may be some kind of a lesion, like small inflammatory lesion, and persons have something like phantom limb. Phantom limb means a person who has undergone amputation, he still feels the pain. So therefore you can give them local analgesics, steroid injections, transcutaneous nerve stimulations are also mentioned. And a person who has got disc prolapse, minor disc prolapse, you will give them epidural anesthesia so that patient does not have pain. So what I mean to say, you can use local anesthetic agents for relief of pain. All right. Then there is another, I was talking to you this pattern. Whenever a person is having pain due to anything, musculoskeletal problems, or because of infection, or because of inflammation, here what you can do is that you can start off with ordinary pains, level 1. Give tablet paracetamol or non-steroid anti-inflammatory drugs. Okay, there's so many varieties of it. They are available in the market: ibuprofen, acetaminophen, etc. Diclofenac, sodium or potassium, whatever it is. So first line of treatment for pain management is that you give paracetamol and non-steroid anti-inflammatory drugs. And for sometimes a person has got troublesome pain because of which is not getting relieved with this paracetamol or non-steroid anti-inflammatory drugs. You can also use drugs like pregabalin and gabapentin, and it stops the activity. Neuronal activity it's controls, and this is quite useful. And thereafter, I would like to say is that there are certain pains, like a person has got ischemic limbs, he has a very severe pain. Okay, for these persons, what you can do the chemical sympathectomy. That means you can push in and over